Good morning, everyone. Good morning, everyone. I am Dr. Divya Ramyead, and today I'll be presenting on cervical schwannoma. To start off, a case study. A 24-year-old female presented to our ENT OPD with a left-sided neck mass for the past 16 years. She reports it was slowly increasing in size. She also had a muffled voice. There was no associated pain, no referred otalgia, no dysphagia, no breathing problems, and no loss of weight. Her past medical and surgical history were unremarkable. She was a non-smoker, non-alcoholic, and works as a hairdresser. On examination, her ear and nose examination was normal. On oral cavity examination, there was a deviated uvula to the right due to mass effect from the left side. No cranial nerve fallout was noticed. A flexible nasal endoscope was performed. The nasopharynx was normal. However, here you can see there is mass effect leading to the posterior pharyngeal wall and lateral pharyngeal wall compressing onto and abutting onto the epiglottis. You can see here we're unable to visualize past the epiglottis to assess the vocal cord movement. An FNA was then done, however, it was suboptimal for diagnosis. We then proceeded to do a true cut biopsy, and that revealed a benign peripheral nerve sheath lesion compatible with a neurofibroma. This is a CT scan head and neck view, axial view, and here you will start to appreciate a cystic, well-circumscribed homogeneous mass, shifting the trachea to the other side and compressing the vessels. That is better appreciated on this coronal view, where you can appreciate a well-defined homogeneous cystic mass in the left parapharyngeal space, compressing and displacing the vessels laterally and moving the trachea to the opposite side. We then did an MRI scan on T1 weighted image. This is an iso-intense mass extending from base of skull to the thoracic inlet. And on T2 weighted images, this is hyper intense and measured around 7 centimeters by 5 centimeters by 11 centimeters in length. We then proceeded to consent the patient for an excision of cervical neck mass, plus or minus a mandible split in view of the extension close to the base of skull. The patient was successfully intubated orally. We then proceeded to do a transcervical skin incision, incise the skin, subcutaneous tissue, platysma. You can see we've ligated off the external jugular vein, and we're starting to see the mass. We then defined the sternocleidomastoid muscle, retracted it, and identified the internal jugular vein, the carotid artery, and vagus nerve. Once the plane of the mass was entered, we then did an extracapsular dissection of the mass. The picture on the right here shows the mass removed with nerve fibers that were not attached to any specific nerve per se. This was actually a case of a cervical schwannoma of which the nerve of origin was unknown. Here on the left, you can see the mass and the void it has left inside the neck. That is a rough estimation of the length of the mass, equivalent to that of a marking pen and a scalpel with blade. And this is the neck anatomy. After removal of the mass, you can see the hypoglossal nerve, the carotid artery, the jugular vein, the vagus nerve, the descendens hypoglossal, the ansa cervicalis, and the spinal accessory nerves all intact. Day 1 post-operation, She started eating semi-solids. However, there was a post-operative dysphonia and aspiration to liquids noted. On flexible scope, she had a left vocal cord palsy, but her other cranial nerves were intact. There was no Horner syndrome. It was deemed that the vocal cord palsy could be transient following traction. She was referred to speech for feeding exercise, and a chin tuck exercise was found effective for liquid tolerance. She was thereafter discharged home day 2 post-op. On histology, section showed a well-circumscribed encapsulated mass comprising of proliferation of benign neural and stromal elements. There is no evidence of malignancy, and the neck mass is consistent with a neurofibroma. She is due for follow-up. So let us have a look at what are cervical vagal schwannomas. Schwannomas as such are benign tumors originating from the cranial, peripheral, or autonomic nerves, except for the optic and olfactory nerves, as this lacks Schwann cells. 25 to 45% of schwannomas are found in extracranial head and neck. 10% either arise from vagus or from the sympathetic nervous system. Cervical schwannomas can be grouped as medial or lateral. The medial ones arise from the cervical sympathetic chain or the last 4 cranial nerves, and the lateral ones arise from the cervical or brachial plexus. The most common place for head and neck region where extracranial schwannomas arise is that from the parapharyngeal space, and they're usually of vagal origin. It has been found in literature that they tend to occur between 30 to 50 years of age with no sex-related predisposition. Less than 5% may undergo malignant transformation, and these are usually associated with neurofibromatosis type 2. A literature review by Simsek and al. In 2013 covered 197 case reports, including 235 individual cases. And it was found that the most common presenting symptom of a vagal schwannoma was that of a painless neck mass. This was then followed by cough, hoarseness, dysphagia, dyspnea, vocal cord palsy, neck pain, and Horner syndrome. Of note, hoarseness or paradoxical coughing during palpation of the mass is unique to vagal nerve schwannoma. And symptoms such as dysphonia, dysphagia, dyspnea, pharyngeal or airway obstruction correlate with the schwannoma size. It's important to keep in mind differential diagnosis. Other than a neurofibroma, this could be a metastatic lymph node, a lymphoma, a paraganglioma, a glomus vagale or carotid body tumor, schwannoma arising from the cervical sympathetic plexus, a bronchial cleft anomaly, cystic structures of the neck, or vascular malformation of the neck. Amongst investigations, we can do a FNA, an ultrasound, a CT, or an MRI scan. Regarding fine needle aspiration cytology, as well as it's a routine procedure for diagnosing the origin of all neck masses, it has been found quite controversial in literature. The quality of the specimen and experience of cytopathologists influence the preoperative diagnostic accuracy, and it has therefore been found that if a cervical mass clinically and radiologically is suspected benign, it is not recommended to do a needle or open biopsy as the treatment is still surgical and it may increase the risk of bleeding, hematoma, and hoarseness. Therefore, imaging is of importance, where on ultrasound, the schwannoma will appear as a round or elliptical cross-section with clear border, homogeneous to heterogeneous with cystic changes. On CT scan without contrast, it will be hypodense compared to the muscle, and with contrast, there will be some degree of enhancement. The MRI scan is the gold standard for differential diagnosis and treatment planning of vagal schwannoma. On MRI scan, it will appear as a well-circumscribed mass lying between the internal jugular vein and the carotid artery. iso-intense or hypo-intense on T1 weighted images, and hyper-intense on T2 weighted images. That is an example of an MRI scan of a vagal schwannoma, where here the white arrow shows the internal carotid artery, and the yellow arrow here is showing a rim of fat, and it is called as the split fat sign, one of the signs we look out for on MRI for a schwannoma. Image B here shows an axial T2 weighted image, again showing the heterogeneous to hyper-intense mass. And image C here shows a post-contrast T1 weighted image showing heterogeneous enhancement of the schwannoma. It is very important for us to be able to differentiate vagal schwannoma from sympathetic cervical schwannoma. In this paper, 25 publications were analyzed and a total of 106 patients. And it was found that splaying of the internal carotid artery and the internal jugular vein was significantly but not uniquely associated with vagal nerve schwannoma. A multivariate analysis demonstrated that splaying of the internal carotid artery and internal jugular vein with medial displacement of the internal carotid artery carried a 75% probability of it being a vagal nerve cervical schwannoma. Absence of such splaying and a lateral displacement of the internal carotid artery carried an 87% probability of being a sympathetic cervical schwannoma. To illustrate this, here you can see a CT neck of a schwannoma from a vagus nerve. The tumor here is marked by the asterisk. The arrows here are pointing towards the carotid artery, and this arrowhead is the internal jugular vein. You can see how it has splayed the two structures. On the other hand, a schwannoma from the sympathetic chain will displace both the internal carotid artery and the internal jugular vein anteriorly without separating them. It's also important for us to differentiate a schwannoma from a paraganglioma, the reasons being twofold. Firstly, it's dangerous to FNA a neck paraganglioma as there's risk of life-threatening hemorrhage, hypertensive crisis, and capsular disruption with tumor implantation. Paraganglioma may be associated with intraoperative hemodynamic instability and hypertensive crisis due to the acute release of catecholamines during surgery. Therefore, what helps us is a CT and MRI scan, where on CT scan pre-contrast, it would appear as an isodense structure, and post-contrast, it would show homogeneous enhancement. On MRI scan, post-gadolinium MRI sequences will show a salt and pepper appearance. Pathological examination of cervical schwannoma will show common histological features on electron microscopy. There'll be the presence of a fibrous capsule, Antony A areas, which refers to hypercellular areas, and Antony B areas, which are hypocellular areas. There are also cellular zones and verrucate bodies. On immunohistochemical analysis, it would be positive for S100 protein and U7. There are three main treatment options. We could either do an expectant observation for asymptomatic patients or opt for surgery for better long-term results, especially if patients have progressive or symptomatic disease. Or we could opt for radiotherapy for symptomatic patients unsuitable to undergo surgical treatment. The wait and watch strategy is best for patients who are asymptomatic at presentation. There should be patients who are willing and compliant to undertake regular visits and imaging examinations. The protocol can then be switched to an active treatment in cases of radiological growth, change in texture, pain, or new cranial nerve dysfunction. There are three ways of approaching surgical approach. It could be a radical excision, which involves total removal of the tumor, sacrificing the nerve. In this case, a nerve grafting needs to be planned. Or we could do an intracapsular resection, preserving the tumor capsule linked to the perineum and removing only the central part of the tumor, or we could do tumor debulking, but this has high risk of recurrence. The rate of nerve palsy following complete excision and intracapsular dissection is reported to be 100% and 67% respectively. The choice of approach therefore depends on the size, location, and relation of the mass to adjacent vessels. There has been a challenge throughout history regarding how to preserve the nerves, and in this recent paper in 2022, it was found that the electromyography could help to prevent nerve motor paralysis, similar to that is employed in thyroid and parotid gland surgery. However, it's widely reported in literature that if a nerve cannot be preserved during surgery, one must do a primary repair or a nerve graft using microsurgical technique with or without medialization of the vocal cord. It's important for us to look out for post-operative symptoms and forewarn patients while taking consent for the following symptoms. They could be hoarseness syndrome, intraoperative cardiac effects due to vagal stimulation, that is bradycardia. Preoperative and postoperative speech and swallow evaluation must be done, as this is important in voice and swallowing rehabilitation. And it has been found that in 85% of patients, there is vocal cord paralysis. Other common complications that occur include pharyngolaryngeal anesthesia, aspiration, and cranial nerve 9, 11, and 12 palsies. This could be transient or permanent. Horner syndrome is more commonly associated with schwannomas arising from the cervical sympathetic chain. It can occur due to direct injury to the cervical sympathetic chain during tumor excision or indirect injury due to traction on the sympathetic chain. And it is characterized by the following 5 features. There's unilateral pupillary miosis due to denervated dilated pupillae, palpebral ptosis due to denervation of the levator palpebrae superioris muscle, facial anhidrosis due to a denervated pseudomotor fiber of sweat glands, sunken globe appearance due to ptosis, and hyperemia due to a denervated vasomotor fiber. Regarding radiotherapy, this is more of an option for large, inoperable vagal schwannomas and for those who are poor surgical candidates. The choice of radiotherapy is that of stereotactic radiotherapy, where we focus the dose, minimizing damage to the surrounding tissues. However, it has been found to have limited efficacy due to intrinsic radioresistance. And therefore, in recent literature, it has been found that the proton beam radiotherapy can overcome the radioresistance of schwannoma and allow high local control and nerve functional protections. It's important to look out for side effects of radiotherapy, which include pain, swelling, temporary nerve dysfunction, hoarseness, or difficulty swallowing. And therefore, it's important to do regular follow-up imaging to monitor the tumor response and detect complications. To end, this is a nice flowchart which is taken from the paper published in 2023 titled Diagnostic and Therapeutic Algorithm for Management of Vagal Schwannomas in the Head and Neck. If a patient presents with a neck mass, you proceed to do an ultrasound imaging. If the image is not so suggestive of vagal schwannoma, you can opt to do an enhanced CT scan. And once it is suggestive of a vagal schwannoma, the gold standard diagnosis is achieved by an enhanced MRI scan. Once you do the diagnosis of vagal schwannoma, you must see if the patient is asymptomatic or symptomatic. If the patient is asymptomatic, you can wait and see. If the symptoms are progressive, you must then decide whether it's a surgical candidate or a non-surgical candidate. A non-surgical candidate, we must consider radiotherapy, and if it is a surgical candidate, we can opt from the 3 options of either doing a radical resection, an intracapsular enucleation, or debulking. With this, I come to the end of my presentation. Thank you for your kind attention.
Thank you, Divya, for a great presentation, a summary of these schwannomas. Is there any comments?
Thanks, Divya. Divya, can you just remind me what your figures were there for the new kind of intracapsular dissection technique in terms of recurrence and nerve preservation?
Yes, so in terms of for radical excision, there was 100% vocal cord palsy, and 67% if it was by intranuclear resection. Intracapsular resection.
Yeah, I think the one comment is about your FNAs. I think it's relatively fair. I think, you know, when you're distinguishing between a schwannoma and a paraganglioma, which are going to be your two predominant tumors of the post-thyroid parapharyngeal space, they should have relative pattern and mnemonic features on imaging to diagnose them. But if there's any kind of diagnostic doubt radiologically, I think it's fair enough to do an FNA.
Yes, yes.
This is definitely safe. I mean, there's never going to be a case where a paraganglioma is not diagnostic. The only other dangerous scenario is if you've got an aneurysm, but again, that should be readily apparent on imaging and clinically. But yes. I think most of the time, FNA is safe in the parapharyngeal space and often a true cut like we did here. And then just a comment about the surgery, as in the case you discussed, one must also just always be prepared and consent the patient for all approaches and scenarios. So we got this fortunately out through the relatively easy transcervical approach, but we did consent the patient for conversion to transparotid and even a possible mandibulotomy to get it up, because if you looked on those imaging, it was extending high up to the skull base.
Yes.
And then I think just also comment on the, you mentioned that study where they used the splaying of the ICA and the IJV to distinguish between sympathetic and vagal schwannomas.
Yes.
My understanding is it's not that accurate in that 2022 paper which you discussed, where they looked at the capsular technique. I think I remember when they read that, they found that radiological technique of guessing whether it's vagal or sympathetic in origin based on that ICA IJV rule was actually very inaccurate and didn't correlate at all with their findings. So it's a nice technique to use, but I wouldn't hedge your bets on it. And I think they also quoted that in the majority of the time they still were post-operatively unsure whether it was sympathetic or vagal in origin. And of course, like in our case, the patient had a post-op vagal palsy, which makes one suspect that it was vagal in origin, but the whole length of the vagal nerve was preserved. So I suspect it's just a neuropraxia, hopefully for the patient's sake.
Yeah, that's right.
And then my last question was, I don't know if I missed it, there used to be this historic quote that one of the reasons to remove vagal schwannomas is a theoretical risk of malignant transformational potential. Is there any? Has that been dismissed?
It's very scanty in literature, and it's reported less than 5%, but it occurs mostly with neurofibromatosis type 2. So it's very, very rare to get a malignant transformation.
And then my last comment also, I mean, I would think for very small vagal schwannomas or parapharyngeal schwannomas, might want to look a bit more closely at IMRT, because I would guess it would have at least some effect if it was small based on the studies of vestibular schwannomas. But I think, most of the time these tend to present late, and probably too big.
Yeah, but there's some radio resistance that's been reported for schwannomas, and that's why they're now looking at proton beam radiotherapy.
Is that regardless of size?
Yes, regardless of size.
Any other comments from the panel? Does anybody have any questions?